Okay, so we have a lot of symptoms. Right-sided pressure, severe right-sided pressure, going to a lot of doctors to try to figure this out. Your symptoms don't make a lot of sense to a lot of people. You map out this right-sided face that goes into the neck. One might think trigeminal neuralgia, but it doesn't present like that. It's a pressure, it's not a pain, along the same dermatome. Middle ear myoclonus, Tietze syndrome, hypermobile. Basically the hypermobility, Gilbert syndrome, digestion problems, which we've come to expect when we see this kind of stuff. Your digestion will turn off. All right. And really the diagnosis is going to be a dysafferentation. So we'll go right to the main finding. When you were lying here on the scan, the technician said they tried to straighten you, and this is kind of where you are. There's a lack of proprioception, there's a dysafferentation. So actually saying lack of proprioception might not be accurate. It's more of that you're getting plenty of proprioception, it's just wrong, incorrect. So yeah, as we dissected this apart, sure, we see that the odontoid is sitting off to the side of the atlas, but that's going to be secondary to these muscular contractions and dysafferentation that's occurring. And here we go, you can probably already see it. You've got the biggest finding that we've found when it comes to these first ribs. So your first ribs aren't even attached. If I did 3D modeling with a 3D printer, they would be 3 separate pieces. And actually, let me clean that up a little better. So you can see that the first rib is not attached here, and it's also not attached in the front. In the past, we've seen them where one side will be down, still attached, and causing the whole neck to twist, turn to one side, and the C2 to rotate, and some nasty stuff. And then when they kind of go on both sides, it pulls the neck forward. So yours are basically not touching on either side. There's the space there, complete dislocation, and on the back, well, there's a little artery in there, but they're just barely touching in there. You can see all the space in there, all the space in there. Okay, so what's that going to do? Well, we have these scalene muscles. I'll tell you what, you don't even have to be a doctor. Just look at this mechanically. These scalenes attach to this first rib. The first rib has the anterior scalene, which is, look at how the size of that muscle, and you can just see how that's going to stabilize and keep you from having a bobblehead. And there's the middle scalene. So just picture all of those turned off or giving wrong information up to the brain. And that's basically the thing that we think is driving this whole thing. We can come up some screenshots to tell the story, but I'm just gonna, that's pretty much the whole thing. Let's see. Yep, you can see how far they've dislocated there. See the space. I measured it 2 millimeters there, 1.5 millimeters there. There you go. So we need somebody to reattach those. Right now, Prolo seems to be the only thing that we know about. This is a ligamentous attachment in there, through there. When I sent this to the thoracic surgeon, he says, you know, hopefully Prolo will work, and maybe somebody will fuse it. I don't know. We don't know anybody that treats these yet. All right, so we put a line through the center of your foramen magnum. Now your foramen magnum has a rotation to it. It's not sitting in it's not straight line according to the skull. So because of that, we used a different vector here, and there's the atlas added. So we're basically saying it's more of a rotation problem. Now, when you analyze this by X-ray alone, you're confined to just finding the center of gravity of the skull and how that loads through the cervical spine. And that's the metrics that we've used in the past to come up with a vector to adjust the atlas. So since we have a CT, we're able to see the foramen magnum, and sometimes the highest priority is not the center of gravity or the center of mass of the skull loading through the center of the neck. Sometimes it's a jugular vein, or it's orienting the atlas to the foramen magnum, in this case, which is rotated. And that's what we did today. We took some measurements, and again, I think that the bobblehead activity is causing a looseness in the upper cervical, and you didn't seem actually too loose up in there. I don't think it's a primary thing, and you don't have any traumas. Nobody's put you in a headlock. These are left and right head rotations. It kind of moves, but I don't think it's a primary thing. I think it's these first ribs. We saw some tortuous arteries in there. There's a good shot. Right, so if we have a dysafferentation, if we have the muscles that can't modulate, I did kind of come up with a diagnosis or a speculation that the logisimus on the left is contracted or not modulating correctly. Your scalenes aren't going to modulate correctly. Your splenius is going to be in play and trying to stabilize and keep your head upright. Again, another levator. The levator is also going to be in play. It attaches all the way up to the top of the cervical spine. And the obliquus superior, I think that's having a hard time modulating correctly. And this is just based on the pattern I saw from the CT scan, the way you just lie down on a table, the way you just are in space. We did tape you up. We ran a lot of KT tape on you today to try to give you a better proprioception, or so you don't feel like you're just being driven. Oh yeah, speaking of being driven, the sympathetic input that's going on must be significant. So I applaud you for holding it together emotionally through this, because this can't be a fun ride. Right, so the stellate ganglions are located. Everybody's anatomy is a little bit different, but a lot of the books have it right below the first rib. So they do PTSD treatments by injecting the stellate ganglion with doing a stellate ganglion block, and that seems to help a lot of people. So I expect your sympathetic. Well, it is being driven pretty crazy. And yeah, we see some granulomatous tissue, some swelling at that joint capsule there, or at that capsule right there at the transverse ligament behind the odontoid process. Yeah, almost 3 millimeters that distance between the first rib. And that's really the gist of it. Anything you want me to talk about? Yeah, whatever hypermobility there is in the top, I think it's coming from the bottom. I really think it's about all I have to say. Any questions?
No questions. I think you covered it all.
All right, thank you.